So good morning, everyone. Today I'm going to teach you metabolic pathways of carbohydrates other than glucose, like fructose, galactose, alcohol, methanol, glycosaminoglycans, and glycoproteins. I'm Dr. Ravi Babu, MD Biochemistry, Assistant Professor from Mallaradi Institute of Medical Sciences. So, and before that, we are going to know about discuss structure and function of glycoproteins, differentiate the blood group antigens, structural components of proteoglycans, congenital disorders of glycosylation and mucopolysaccharidosis, tabulation. This one table of inborn errors associated with carbohydrates metabolism. So here, account or competency, how they ask, describe and discuss the regulation, functions, and integration of carbohydrate along with associated disease disorders. So fructose metabolism is a ketohexose present in fruits, honey, and sucrose. Fructose promptly metabolized by the liver. So how they look like? See fructose here. Just fructose. So fructose to fructose 1-phosphate presence of 1-phosphate fructokinase, but absent in fructosuria. Fructose phosphorylated by fructokinase. Fructokinase phosphorylate first position. So fructose, that's the important for fructose 1-phosphate. Hexokinase action is on the sixth position. See the difference. First with help of fructokinase, sixth in hexokinase in glucose 6-phosphate. Fructokinase is not dependent on insulin. So now fructose to fructose 1-phosphate, glyceraldehyde, and glyceraldehyde 3-phosphate. How they convert? Fructokinase change fructose to fructose 1-phosphate, and aldolase B that changes fructose 1-phosphate to glyceraldehyde, and glyceraldehyde here triose. See 1 2 3 1 2 3 glyceraldehyde and dihydroxyester phosphate 3 carbons. Triose kinase ATP split to ADP. The phosphate group attached here. So already phosphate group is there, but energy is dependent. That is ATP is required. So here glyceraldehyde 3-phosphate and the free fructosine. But important that aldolase deficiency, there are some disorders also there. Free fructose in large quantities seminal plasma. The energy for mobility of spermatozoa is mainly derived from fructose. Secreted by seminal vesicles, some person azoospermia due to block in the duct. So fructose is made in semen. Fructose present, the block is above the seminal vesicle duct. If absent, block is after the seminal vesicles. Before and after that will decide. If fructose present, that shows the block is above the seminal vesicular duct. If absent, block is after the seminal vesicles. Hereditary fructose intolerance, autosomal recessive. So 1 in 70% carriers of abnormal gene, aldolase B. So vomiting and loss of appetite, hepatomegaly and jaundice can occur when sucrose or fructose introduced in diet of infant, usually around 6 months. Fructose exceed in urine. Urine gives positive Bendix test. Accumulation of fructose 1-phosphate will inhibit accumulation of that will inhibit glycogen phosphorylase, and this leads to accumulation of glycogen in liver associated with hypoglycemia. The infants often fail to thrive if liver damage progress, cirrhosis, and death. Withdrawal of fructose from the diet will immediately relieve the symptoms. So seen in sucrose, fructose content diet in the diet of infants about 6 months of age. Accumulation of fructose 1-phosphate will inhibit glycogen phosphorylase. That leads to accumulation of glycogen liver, so hypoglycemia. What is fructosuria? Benign metabolic defect due to fructokinase excretion of other than fructose. So there is no abnormality other than excretion of fructose in urine. And see now, so fructose not dietary essential. Urine gives positive Bendix test and Selinov's test. So incidence is in 1 in 130,000 births. So galactose metabolism. Galactose is a constant of lactose, which is monosaccharide, milk sugar. It's not an essential nutrient. UDP glucose can form UDP galactose. Galactose metabolism excreted by the liver. UDP galactose active donor of galactose during synthetic reactions. So here now see now galactose galactose necessary for synthesis of the following. So lactose synthesis, UDP glucose, presence of apomerase, they change to UDP galactose. Lactose synthase, they synthesize lactose when UDP galactose bind with glucose. Lactose synthesis seen in lactating mammary glands. Sense of glycosaminoglycans, cerebrocytes, glycolipids, and sense of glycoproteins. So overall, how do you see the metabolism of galactose? Now see, it's very easy to galactose 1-phosphate, galactokinase, presence of ATP, 1-phosphate, first portion, and UDP glucose change to UDP glucose 1-phosphate. In presence of galactose 1-phosphate, it will transferase. If there is a defect in GALT enzyme, galactose 1-phosphate, it will transferase. We'll see galactosemia. So UDP galactose interchange to UDP glucose, simple enzyme that is uridyl diphosphate galactose epimerase, UDP gal epimerase. Galactose 1-phosphate directly can synthesize UDP galactose 1-phosphate phosphorylase. So alternate pathway. Galactose 1-phosphate pyrophosphorylase in liver that becomes active only after 4 to 5 years of life. The enzyme will produce UDP gal directly, which can be converted to UDP glucose. What is galactosemia? Inborn errors, 1 in 35,000 births. Galactose 1-phosphate uridyl transferase, that's a deficiency enzyme. This galactose 1-phosphate accumulates in liver, which inhibits glycogen phosphorylase. See, neonatal hypoglycemia, you can see. Bilirubin uptake is less and bilirubin conjugation is reduced. So unconjugated bilirubin level is increased in blood. Enlargement of liver, jaundice, severe mental retardation. Free galactose accumulates leading to galactosemia. It's partially excreted in urine galactosuria. Galactose reduced to dulcitol. Accumulation of dulcitol in the lens results in cataract due to its osmotic effect. Galactose 1-phosphate may get deposit in renal tubules, producing renal damage leading to generalized aminoaciduria. What are clinical features? So we'll see in the clinical features. Here, from top to down, mental retardation, congenital cataract, and jaundice, hepatomegaly, kidney damage, galactose and amino acids in urine, hypoglycemia. So diagnosis of galactosemia, clinical manifestation, congenital cataract, presence of galactose in urine as well as elevated blood glucose level will help in diagnosis. How we confirm deficiency of enzyme WBCs, collection of fetal cells by amniocentesis for prenatal diagnosis. Treatment of galactosuria. Lactose-free diet. Special diet may be withdrawn after 4 years when galactose 1-phosphate phosphorylase becomes active. If lactose withdrawn from the diet, most of the symptoms are receded, but mental retardation, when established, will not improve. Early detection is more important. Galactokinase deficiency. A variant disease due to deficiency of galactokinase. Symptoms are mild because galactose 1-phosphate is not formed and no toxic effect of this compound are manifested. So cataract is seen. Galactokinase deficiency reported in 1 in 40,000 births. Neonatal hypoglycemia due to glycogen storage disease type 1, fructose intolerance, galactosemia, medium chain fatty acyl-CoA dehydrogenase deficiency, long chain fatty acyl-CoA dehydrogenase deficiency, and metabolism of alcohol. Alcohol absorption starts from stomach itself, but most of it is absorbed by intestine. 1% of ingested alcohol is excreted to the lungs or urine. Major fraction of alcohol is oxidated in the liver. ADH. It is an NAD-dependent cytoplasmic enzyme that oxidizes ethanol to acetaldehyde. Alcohol dehydrogenase is a dimer, has 6 isoenzymes. In some individuals, the enzyme is mutated. This mutation rate is more in Orientals. In such individuals, alcohol metabolism is slower Even small quantity of alcohol may produce intoxication. Alcohol dehydrogenase. Acetaldehyde is further oxidized to acetate by a mitochondrial NAD-dependent enzyme. The acetate is then counted acetyl-CoA. Here, the activity of alcohol dehydrogenase is more than aldehyde dehydrogenase. So, acetaldehyde accumulates in liver. Acetaldehyde is toxic. Aldehyde is toxic, which is excess may lead to cell death. Active aldehyde dehydrogenase less in Indians when compared to Europeans. See ethanol to acetaldehyde again. So here we change alcohol dehydrogenase to ethanol is acetaldehyde, aldehyde dehydrogenase. So here we'll get the remaining product. So mechanism of ethanol oxidation system, MEOS, it's another mechanism of detoxification of alcohol. It's cytochrome 450 P450 dependent and it is inducible. So metabolic intolerance of alcohol observed in chronic alcoholics. So biochemical alteration alcoholism. Both the oxidation steps of alcohol produce NADH, resulting in high NADH by NAD plus ratio. Several metabolic adaptations also occur. In cytoplasm, high NADH level favors conversion of pyruvate to lactate, leading to lactic acidosis. Deficiency of pyruvate lead to inadequate formation of oxaloacetate that result in depression of gluconeogenesis, leading to hypoglycemia. Reduced oxaloacetate or decreased pyruvate, high NADH cause suppression of TCA cycle, acetyl-CoA is accumulated, which favors ketogenesis. And increased level of acetyl-CoA cause increased fatty acid that is oxidized, that's not oxidized, fat accumulated liver that leads to fatty liver. So alcohol also increases release of reactive oxygen species, leading to mitochondrial damage and apoptosis. Lactic acidosis causes decreased excretion of uric acid, resulting in acute attack of gout. Alcohol causes CNS depression by inhibiting excited receptors that N-methyl aspartate receptors by potentiating inhibited neurotransmitters, GABA receptors. What about chronic alcoholism? Alcoholism and liver accumulation of fat in liver cells leading to fatty liver and accumulation of toxic effects of acetaldehyde leads to cellular death. This is followed by replacement of fibrous tissue, fibrosis of liver, cirrhosis, which when liver functions are reduced, hepatic coma results. Alcoholism nervous system. In chronic alcoholics, the brain ventricles are enlarged, neurons are lost, neurodegenerative changes set in memory is affected. In alcoholics, combined thiamine deficiency lead to Wernicke's disease. Aldehyde inhibits pyridoxal phosphate, hence neuritis is common in alcoholics. Lab findings in chronic alcoholism. Increase in serum level of gamma glutamyl transferase and alanine transaminase. Decrease in aldehyde dehydrogenase activity, liver cells and RBC is the best marker for alcohol abuse. Desacylated transferrin level in blood is highly sensitive marker for chronic alcohol abuse. Metabolism of methanol. It's methyl alcohol, methanol or methyl OH. That's odd is similar to that of ethanol and then often used for adulteration of drinking alcohol. So methanol is far more toxic than ethanol. This is produced from pectin in fruit. Methanol produced naturally the anaerobic metabolism of certain bacteria found in environment. Toxicity. As little as 10 ml of pure methanol can cause permanent blindness by destruction of optic nerve, while 30 ml is fatal. Toxic effect begin hours after ingestion. It's metabolized to formaldehyde by ADH, alkyl dehydrogenase, aldehyde. In this, formaldehyde is further converted to formic acid by ALDH. So formaldehyde is toxic because it inhibits mitochondrial cytochrome C oxidase that cause cellular hypoxia and metabolic acidosis. So major toxicity manifest is loss of vision. Decreased vision may start as early as 12 hours after exposure. This may be accompanied by vomiting, abdominal pain, decreased consciousness. Death may occur even after drinking a small amount. Thank you.